Hi, I'm Evan Winograd, a neurosurgeon at North County Neurosurgery in Carlsbad, California. If you're watching this, you or someone you know has probably been told they have a herniated disc in their neck. In the next several minutes, this video will cover what a cervical disc herniation is, why it causes those specific symptoms, and how this condition is generally managed. Before we get into it, please take a moment to review the important notice on the next slide. Before we begin, this video is intended for general educational purposes only. The information presented here is not a substitute for professional medical advice, diagnosis, or treatment. Every patient's situation is different. If you have questions or concerns about your own health, please reach out to your doctor or a qualified healthcare provider for guidance that is specific to you. With that said, let's get into it. The cervical spine, the neck, has 7 small bones called vertebrae stacked on top of each other. Between each pair is a disc. Think of it like a jelly donut, a tough outer ring with a soft gel center. At every level, nerve roots branch off the spinal cord and travel down into the arms, shoulders, and hands. The 2 levels most commonly affected by herniation are C5, C6, and C6, C7, the most mobile levels, which absorb the most stress over time. A herniation happens when that tough outer ring cracks or tears, and the gel center pushes through it. That disc material then presses on one of those nearby nerve roots, and that pressure is what generates symptoms. In some cases, disc material pushes toward the spinal cord itself rather than a single nerve root. That's called myelopathy, and it's an important distinction. Those 2 situations are typically managed differently and with different levels of urgency. Here's what surprises almost every patient. The structural problem is in the neck, but the pain and symptoms show up in the arm. That's because a compressed nerve fires pain signals down its entire length into the arm, fingers, and sometimes the hand. The exact pattern tends to correspond to which level is involved. Thumb and outer arm pain often points to C5, C6. Middle finger and triceps weakness more commonly suggests C6, C7. Those patterns, alongside MRI findings, help identify which disc level is the source. Here's the most important thing to understand about this condition. Somewhere between 70 and 90% of cervical disc herniations improve significantly with conservative treatment, no surgery. The body is remarkably effective at resorbing displaced disc material and calming the surrounding nerve inflammation over time. That's the natural history of this condition. Conservative treatment is almost always the starting point. Surgery is reserved for specific clinical situations, and those are covered later in this video. Conservative treatment typically follows a stepwise approach. Anti-inflammatory medications, ibuprofen, naproxen, or a short course of oral steroids are commonly used to reduce nerve inflammation in the early phase. A soft cervical collar worn for 2 to 3 weeks can help limit the movements that tend to aggravate symptoms. Physical therapy is generally introduced as the initial flare settles, focusing on posture, gentle cervical stretching, and neck strengthening. If significant arm pain persists beyond 4 to 6 weeks, a cervical epidural steroid injection at the affected level provides meaningful relief in approximately 60 to 70% of patients. Surgery becomes a consideration in specific clinical circumstances, not simply because pain is still present. If conservative measures have been completed and arm symptoms are still significantly affecting daily function after 6 to 8 weeks, that's one indication. Progressive weakness, particularly in the hand or grip, generally leads to a faster evaluation timeline. When spinal cord compression is present, timely evaluation is important, as that changes the clinical picture. Any surgical decision typically follows a careful review of imaging, symptom trajectory, and available alternatives. There are 4 main surgical approaches for cervical disc herniation. ACDF, anterior cervical discectomy and fusion, is the most commonly performed. The disc is removed through an anterior approach, and the vertebrae are stabilized with a titanium plate. Published success rates are approximately 85 to 90%. Cervical arthroplasty replaces the disc with an artificial device that preserves motion, generally a better fit for younger patients without significant arthritis and preserved alignment and anatomy. A posterior foraminotomy widens the nerve opening from behind, without requiring fusion or hardware. Finally, a laminectomy is another option. This involves removing the back of the spine to give the whole spinal cord and nerves more space, removing compression from behind the spinal cord, usually caused by ligament thickening. The appropriate approach depends on herniation pattern, anatomy, age, and individual circumstances. Most people with a cervical disc herniation improve over weeks to months with conservative care, but certain changes in symptoms suggest the situation may warrant more urgent evaluation. Progressive weakness in the arm or hand, especially if it's worsening over days, is an important warning sign. Symptoms developing in both legs, changes in balance or coordination, or any changes in bladder or bowel function may suggest spinal cord involvement. Those findings are generally an indication to contact a spine specialist promptly, rather than continuing to wait through a standard conservative timeline. I hope this gave you a clear educational overview of cervical disc herniation, what it is, why it causes those symptoms, and how it's generally managed. A full written patient guide is available at northcountyneuro.com, along with guides for every spine and brain condition we cover. Remember, this video is for educational purposes only and does not replace a consultation with your own physician. If you're looking for a neurosurgical evaluation in the San Diego area, you can reach us at 442-273-5056.